Hello, this is your brain on drugs, and this is the punk rock psychiatrist. So, today we're going to get into the assessment of obesity. So, basically, you probably do this first before all the lifestyle stuff I already talked about. Um, but I wanted to put it right before the medications because I thought it would lead in well. So, when you're first seeing a patient, what are you going to do if they're coming to you with kind of metabolic disorder symptoms, obesity, etc.? Um, or this is a patient that's interested in starting on a GLP-1. They are obviously these medications have blown up and they want to know about it. And you're a psychiatrist and maybe you're not familiar with it, and you're kind of thinking, man, how do I start this? So today we are going to learn how to do that. We're going to learn how to when we meet with the patient before we start medications, what do we want to assess for? So let's go ahead and get started with that. So obviously weight, but there's lots of ways to measure weight. BMI, of course, is the one that we're all most aware of, I think. Body mass index. We talked about at the beginning what kind of the numbers are for different categories, with 30 and up being obesity, and 25 to 29 being overweight, and then different classes of obesity over 30. It's not perfect, but I think it's a good number to kind of track progress. So, someone starts out as a 34, we're coming down to a 31. That's generally going to be a good thing. If they're going up, that would generally be a bad thing. Of course, not everyone with a high BMI is unhealthy, and not everyone with a lower BMI is healthy. So we have to keep that into consideration. I actually think waist circumference is probably a little bit better. And the good news is it's just as easy, if not easier, to assess. So, what we're looking for is we're going in inches here for my crowds that are, outside of the inch using community of the US, and I believe Canada uses inches. You can go ahead and multiply these numbers by 2.54 to get centimeters. And for women, we're looking for, if we're greater than or equal to 35 inches, this would be concerning. And for men, greater than or equal to 40 inches. And I don't know, kind of the cool thing here is it doesn't typically matter what your height is, unless you're extremely tall or extremely short. These numbers hold up because the abdomen doesn't really increase in size very much with height. Okay. Of course, if you're very, very small, um, you know, under 5 feet or even less, or you're maybe over 6.5 feet tall, it might make a little bit more of a difference, but 99% of people are kind of in that maybe 4'10" to 6'6" range. Um, and so actually your waist is kind of determined by your insides, right? So there's not really any bones going on in the waist except for the backbone, right? So if you have larger bones, we're not measuring where the ribs are, we're not measuring where the hips are, we're above the hips. You're going to want to measure um, right above the hip bones and kind of across the belly button. That's where we want to get that waist circumference. And so we're really measuring the the size of what's inside the abdomen, right? And it doesn't necessarily matter so much what your height is, male or female, right? Because females, we have a smaller number here than males. So within female and within male, our size in this area um, is pretty consistent. If we're over that number, that it would be problematic. And what that's essentially indicating to us is fat, right? If you don't have a lot of fat on your abdomen, even if you're very tall, you're not going to have a waist size over that number. And I mean, this is still pretty, I mean, it's pretty generous. I'm 6'2", and I have a 33-inch waist. So So I still have 7 inches to spare before we become concerned, and I'm on the taller side. So I think if you're over that number, it's a very good measure, because we're measuring the really the visceral fat and so forth in there is being taken into consideration, as well as that subcutaneous fat, and that's what we're concerned about, all that fat in the abdomen, right? Another way to measure for weight would be a waist to height ratio. Like I said, height typically doesn't matter that much. We're more worried about the waist. I've never used this. It's another thing you could do. Another one, body fat percentage. This is a bit more complicated to measure. There's two main ways to do it. Using calipers, which is kind of a measurement tool where you pinch different parts of skin. And there's different ways to do it. The easiest way that I know of is you pinch in 3 places. Belly button, you basically put it on the belly button and then pinch to the side. And basically when you pinch skin, what's in between your fingers is fat. Okay. So whatever you're kind of grabbing onto, your skin layer is very thin, and when you pinch it like that, there's no muscle in there. This is mostly fat. And so the more that you're in that pinch, the more fat you have. And so if you go into that belly button area and then pinch the side and then measure how many millimeters that is, that would be the fat measurement there. And then we do a chest measurement, which is it's kind of closer to the armpit area, where you're going to kind of go armpit to chest. There's a pinch site there. And then thigh, you're going to go kind of on the front anterior part of the thigh, right in the middle, and pinch that. And essentially, you take those millimeter measurements and you plug them into a long formula, and it comes up with an estimate of body fat percentage. Another way to do that is a bioelectrical impedance. So we have one of these at my gym. Doctors' offices have these. I think these are really great. You basically stand on it and you hold onto these handles, and it puts some electric signals through, and it measures, and basically it can tell by, I guess, how long it takes to get from your feet to your hands based on your height and weight and everything, like how much of your tissue is fat. And it's pretty amazing, because it will measure your fat in all different, it'll measure your visceral fat, it'll measure your fat in your upper body, your lower body, it measures muscle. um, I like to do this to check my own body fat percentage, trying to get it down lower, by doing my lifestyle techniques. And so, if you're someone taking this really seriously, you might want to um, track yourself and if your doctor's office is really serious about this, you might want to purchase one of these machines, because it's a really accurate way. And that visceral fat number is a really good measurement of how their metabolic health is. All right. And then those are kind of the different ways to measure weight. It's up to you which ones you want to use and how you want to use them. But of course, we're going to want to track that over time. And so that's a really good way to do it, where you're kind of looking each time. BMI is the one, it gets entered into the medical record often, so it's like really easy to look at, and you can see past measurements. You can even see measurements often from visits that weren't your visits, that when they saw other doctors, because they measure height and weight. And so you can get that tracked that way as well. So that's what I would recommend. You're going to have to, when you're doing an assessment, we certainly want to assess what their current weight is. The other thing about BMI is that's the number that's going to key in for insurance and for, like, basically the approval to use this medication or these medications. Okay. So assess weight, and then assess social history. I know a lot of places have a social worker that will do a lot of this initial workup, kind of getting a full history and assessing of the patient to kind of figure out what's going on, to see, is this a kind of patient that would benefit from medication or not, save the doctor a little bit of time, kind of send them and say, hey, I think we should start some meds on this patient. So like social history is something you want to go through, family history, lifestyle factors. kind of assess what's their current lifestyle, what is their diet like, what is their exercise like what are they doing right now, what is their, are they unable to sleep because they have young children, or are they stressed about something, did they just lose their job, are their parents obese, do their parents have diabetes, do there's their siblings, are there heart attacks in the family, so assessing that can help you get a better idea of risk and just kind of what their life is like. And you may kind of think, oh wow, I don't know that we need to do meds, maybe we need to address this social factor with some therapy or nutrition consult or something like that. So important to kind of find out like how, you know what their life story is. All right. Another thing you're going to want to do is you're going to want to, if you're kind of like, yeah, I think this patient is too heavy, we're going to want to screen for things that could go along with that, right? So we're going to want to look, is there cardiovascular risk here? Is there diabetes risk? High cholesterol risks? Triglycerides? Blood pressure? Sleep apnea? Um, Fatty liver stuff? G- um, the acid reflux symptoms, GERD, depression, anxiety, difficulty with sleep, chronic pain. So like what things that kind of go along with high weight might this patient have? So we should assess for those things. And some of that's going to be oral history, and some of that will be laboratory workup. Some of it will just be history. It'll be like, yeah, I'm on this med. So, oh, you have a history of depression. You have a history of acid reflux because you're taking this medication, and you're still on it and feel like you still need to be, and it's being followed by somebody, right? So we kind of want to, and then we want to make sure, like, well, maybe it hasn't been picked up yet. Maybe this is something that's going on that they haven't talked about, right? And then I think one thing we really need to, when we talk about like metabolic health, how do you diagnose metabolic syndrome? There's 5 symptoms, and they have a lot to do with those things we just talked about. So it's like high blood pressure, um, insulin sensitivity, so like diabetes, prediabetes, low HDL. But we're kind of learning that like that's less important now, but it's still one of the factors in metabolic syndrome. I don't believe that they've got removed that from the criteria, but I'm hearing more about like how having a high HDL is not necessarily that awesome. It's more like, oh well, but it doesn't really matter necessarily what your HDL is, but a high LDL is bad. But like, I think we used to think more like, oh, it doesn't matter what your LDL is. If your HDL is high, it kind of cleans it up. Well, now we're finding out that that's not actually the case. So we really need to pay attention to that LDL. And but that but still in the metabolic syndrome criteria, HDL below, I believe, 50 for women, below 40 for men is considered like a check mark of, oh, that's one symptom of metabolic syndrome. And then high triglycerides, I mean, it's like over 150. So you look at those 5 factors, and if they have two, I believe it's 2 of them, then they're diagnosed with metabolic syndrome. And then some interesting information would be like, well, okay, maybe you only have one of them, or maybe you have 2 of them. So you may not have the diagnosis. Sorry, I said that it was 2. You need 3 of those symptoms, and so 1 or 2 is still not great. I mean, you don't want any of those symptoms, but this is an interesting statistic here. So only 12.2% of Americans don't have any of those symptoms, right? So, and this is, I believe this is adults 18 and older. It might be 20 something, but I believe it's 18 and older. So that means that 87.8% of American adults either have like prediabetes, low HDL, high triglycerides, high blood pressure, um, or what's the last one? Or the sorry, the waistline over 35 inches for women and 40 inches for men, right? And high blood pressure is considered over 130 for the top number, and over 85, equal to or over 130 over 85. And then the pre-diabetes, the way that they have it in the diagnostic criteria is over 100 for glucose, fasting glucose, and over equal to or over 150 for high triglycerides, um, and then the HDL I mentioned. So we're not doing well. Our obesity rate is 40% and climbing, but even if you're not obese, it doesn't mean you have metabolic health. Only 12% of Americans are good on all those categories. And that doesn't necessarily mean that those 12% are in amazing health either. But we know that if you're not in that 12%, you've got one serious problem at least. And if you're in that 12%, you might still not be healthy just because you don't have any of those symptoms. So not a lot of folks healthy out there. And so we have a lot of room for improvement. So that's what I would do. I would screen for those conditions. And then I would look at, before I was going to give someone weight loss medication, I would want to kind of assess, is there something causing this, some sort of medical issue? And there's a few. Lipedema is one that a lot of people may not have heard of. I didn't hear about it until a few years ago. We're going to talk about lipedema at the end. This is something that I believe is only found in women. And it's when you have like really big legs and hips, kind of specifically, but it's the way the fat is kind of like, that's like the body habitus, like the shape that we typically see. And it's kind of the way the fat is stored. And we'll talk about that at the end of the obesity series. So you'll learn all about lipedema and the other conditions that kind of look similar to it. And the bad news is that the weight loss medications don't really work for lipedema. There's also like pain associated with it. So it's like large tissue in the lower half of the body, and there's pain associated with that. And it's the way the fat's distributed, and it doesn't respond to medication. So you're going to want to kind of suss that out so that you don't treat them and they don't, they're not going to get better. It's hard to treat, actually. We'll talk about what the options for that are when we discuss it. Cushing's syndrome, another secondary cause. It's very rare. You're probably not going to run across very many Cushing syndromes in your career. And it's something that you would suspect, based on criteria for Cushing syndrome. Certain places that we see fat, like on top of the clavicles, like you almost have to see something like that. So you're looking for these fat depositions in certain places in the body. You're looking at like the shape of the face, typically thin limbs, but very large abdomen area, striations, so like purple streaks, kind of like stretch marks that are purple. You're typically going to want to see quite a few of these symptoms. And I believe the fat pad thing is like, if you're not seeing that, then you shouldn't even be considering it. And then it's a pretty easy thing to test for. And it's something that you would want to refer to endocrinology. And of course, this is not a patient that you're going to want to give weight loss medication to because they have an adrenal issue that needs to be addressed. All right. So this is, that they're producing like too much adrenaline, I believe, is what's going on there. And we have to figure out why that's happening and then what to do about it. Next, secondary hypogonadism. So hypogonadism, we talked about that actually in the depression series, where you're not producing enough of the sex hormones. Secondary, there's primary versus secondary. Primary is like when it's happening in the pituitary, because the pituitary signals the sex organs to release their hormones, and then they're actually produced in the testes and the ovaries. And so secondary is whenever they're not being produced in the testes and the ovaries, and we're typically with the secondary hypogonadism. This is mostly a male issue. So you would test for like testosterone. So, if they've got symptoms, I have an episode on low testosterone, so check that out for like more details. But essentially, if they have low sex drive and difficult, erections are not happening, they're not interested, low libido, no energy, uh, things like that. It can't hurt to go ahead and check the testosterone, see if that's the issue, because that can lead to obesity. All right. Another one, hypothyroidism. So, thyroid, we don't have enough thyroid hormone. Most folks are checking for this and they've been checked for it, but that this could cause obesity. PCOS, polycystic ovarian syndrome. So, it's a female condition. Um, so, you would want to, if you were suspecting of that, oftentimes we're seeing, facial hair with this, not always, but obesity, uh, their menstrual cycle is irregular. You do an ultrasound and there's cysts on their ovaries, right? So there's like some diagnostic criteria. This is not something that I am doing in my assessment, the full thing, but I might suspect it and then send them to somebody to do this workup because I'm not doing an ultrasound. I don't know how to do them. So that's another thing that could cause obesity. And so I'm not sure how well that would respond to these medications or not. But you certainly want to have them assessed for a medical issue that they have, and not just go straight into weight loss medications. All right. So those are some secondary causes. There's some others that are like extremely rare that you really don't need to know of. And even like Cushing's is pretty unusual. And then even with hypothyroidism and hypogonadism, um, treating that may not even resolve the weight issue, right? Like we always hear, oh, hypothyroidism, you gain weight. Well, I've seen plenty of hypothyroidism uh, patients that then get thyroid, but they are still overweight. So you would, of course, want to address a medical issue that they have, but don't expect that they're actually going to lose the weight necessarily. They may not, you know, when you've got like over 40% of people in the United States that have obesity, you're going to have patients that have thyroid and hypogonadism issues, and you're going to treat it and they're still going to be obese because maybe it wasn't related or maybe it was a tiny contributing factor. I've seen patients with hypothyroid and they think, "Oh man, I had that's why I'm so big." And then you address it and their weight doesn't change at all. So, of course, you're going to want to address the PCOS and the secondary hypogonadism, the Cushing's, the hypothyroidism, um, before you address their obesity with medication. However, you may still need to address it. Like I wouldn't expect, oh, I found the cause of your obesity. It's this. Not necessarily. And like honestly, even though those can be causes, I've almost never seen um, resolution of obesity when those issues were addressed. And part of that might just be, I mean, we've talked about this before. Once you've gained the weight, it's quite difficult to get it back off again. And so these patients have gained it maybe because of the secondary cause. So I mean, we need to plug the hole by, like, oh man, this is like causing this obesity to occur. And so let's fix the issue. However, they're not necessarily going to lose all the weight, and we may have to still use the medications to then treat that as well. But we, of course, want to address the medical issue first. All right. So those are the secondary causes, things that could cause obesity that I would look at. And then the next thing is I would look at some conditions that may affect what medication we choose. Now, some of these things would lead us to choose a certain medication, and some of these things would lead us to not choose a certain medication. So let's kind of go through those factors. So like migraines, topiramate is something, Qsymia, topiramate, phentermine is used to treat obesity, but topiramate helps with migraines. So you might want to consider this medication if we have a patient with migraines. Maybe they're already on topiramate. Maybe we add some phentermine to that. Okay, so Constipation, sometimes patients get constipated when they take GLP-1s. Um, we would want to be mindful of that. They already have constipation issues. So we have to, maybe increase the treatment of constipation that they're getting if that's a medication we're going to use, or we might want to avoid it depending on, if things get worse. Diarrhea, some of the medications can affect things the other way. And so, hey, if they've got diarrhea, if they get a little bit of constipation from a GLP-1, that might actually help with that issue. So that might be one that we would be looking for. MIN2s, multiple endocrine neoplasm type 2. That is a extremely rare disorder. I've never seen it. It often comes with medullary thyroid cancer, and medullary thyroid cancer is a black box warning for GLP-1s because, well, you'll find out when we talk about it, but there's concern, it happened in mice. I don't think there's ever been a single case in humans of people who got medullary thyroid cancer after they started GLP-1. It's a very rare form of cancer. MIN2 is an even more rare disorder that you are at increased risk of medullary thyroid cancer. So we can't use GLP-1 medications with these two conditions. So we want to make sure they don't have them. Seizures is another thing. Bupropion. So we've got, contrary bupropion, naltrexone. Not going to want to use bupropion if they have seizures. Glaucoma. So like if they've got like a phentermine, some of the medications that increase blood pressure do not go well with glaucoma. It can worsen that condition. So there's contraindications there. Kidney stones. So topiramate can increase risk of kidney stones. So if they have a history of that, we'd probably want to avoid that medication. Pregnancy, for females, we don't want to use any of the medications. Metformin is something you can use, but like that's something I would defer to who's managing their pregnancy. But generally, we're not going to want to use medications in pregnant women, and they're actually contraindicated. Pretty much everything is contraindicated. All the FDA-approved medications are contraindicated in pregnancy, with metformin off-label being the only one that you could even think about. Bulimia and even like Qsymia actually has a warning for don't get pregnant on this medication. It's part of the RIMS requirement. So are they pregnant, or are they planning to become pregnant? That's going to affect whether we use medication or not. Eating disorders, especially bulimia. I mean, you're probably not going to have anorexic patients coming in. And if you do, you're probably not going to give them meds. But I know a lot of treatment is done online, and you might have patients that are sending false pictures of themselves. They're misrepresenting themselves. They actually have anorexia, and they're trying to get these medications to, feed their disorder of anorexia. I'm going to have a whole slide where I talk about eating disorders and GLP-1s. There's a lot more to it. Bulimia, that this is something where patients tend to be normal weight, and you can actually be overweight or obese and have bulimia. And so that's something that, you would want to be mindful of, whether we're feeding into that disorder with the medication that we are giving. Like I said, we will talk about that later. Another thing that I'm going to want to assess are two kind of aspects here: their motivation for weight loss and their expectations for weight loss. So motivation is important because I want to know, are they all in on this? Because there's no point in doing it if they're not going to like follow the plan. This is not simply like take a pill, take a shot, and set it and forget it. There needs to be, they need to actually like change their activity, that change their diet, their exercise. I mean, I know patients that they eat through the GLP-1, right? It's kind of like people who drink through and abuse, right? Like you give them this medication, you think it's supposed to make them sick when they drink alcohol, and they just drink over it. And somehow they are managed to like take the med but still drink. It's not really doing them any good, right? Same thing with the GLP-1. You have people that like they eat through it, and they're just like nauseous, and they just don't care, and they just compulsively eat anyway. And even though they're getting the help, they're not actually following through. And so then why are we giving them the medication if they're not motivated to make changes, right? So that's something you want to assess. And then expectations. Everybody wants to look a certain way. Um, some people thinner than others, but almost everyone wants to look thinner than they currently are. And they may not be able to reach the goal that they have set for themselves. And so it's important to know, as the provider, what's their end goal, and is this realistic? And it might be realistic, but it might not be a high chance they're going to get to that point. And we need to educate them and be like, okay, I understand this is what you're trying to get to, but if we get to this point, I'm going to be happy, and you're going to be healthier, and that might be as good as things get. How would you feel about that? Okay, so that's something important to assess. And then we're going to want to do a lab workup to check for all these conditions that I've talked about, the ones that we can check for with labs. So A1C, fasting plasma glucose, complete metabolic panel. We're especially looking kind of at liver in there because, um, MASLD, fatty liver type of stuff we're assessing for. TSH, looking for thyroid stuff. Lipid panel, getting all the cholesterol, triglyceride information there. So we want to see if they are already having issues. And this could also assist us in like what treatment. And we may find out, oh my gosh, you actually have diabetes, we need to give you medication for diabetes. And good news, the GLP-1s are much easier to prescribe to someone who has diabetes as opposed to those who doesn't, and get it covered by insurance. And so we might actually get to use those medications sooner, rather than go through a bunch of other stuff before the insurance company will approve it. And so finding out that information is going to be vital as to helping us know how to treat this patient. All right. Next thing, I'm going to want to know about what medications they're taking, because a lot of medications could be causing obesity. And a lot of those meds are our meds, psych meds. So antipsychotics, clozapine being the biggest offender, olanzapine would be next, then quetiapine, then risperidone. It's possible with all of these second generation antipsychotics, but those kind of in order are the biggest offenders. Antidepressants, we're looking at mirtazapine, tricyclics, SSRIs. All of I had previously thought paroxetine, Paxil was the worst. I have now heard escitalopram, Lexapro, my favorite SSRI, is actually the biggest weight gainer. You can gain weight on pretty much any serotonergic medication, but I generally think of them in that order. I mean, even trazodone. I'm seeing. I reported that information on a previous episode where we talked about. I think it was in the it was in one of my quick takes, like number 6, I think, where I went over a new study that talked about like which medications were the biggest offenders, and so reference that. I believe it's quick take number 6. The mood stabilizers. I mean, of course, divalproex, Depakote being the biggest offender, followed by carbamazepine, lithium, gabapentin, pregabalin. This is pretty much all of our medications. Antihistamines like Benadryl diphenhydramine, cyproheptadine. I don't use a whole lot of that, but I've seen it used for nightmares. I've seen it used for sexual dysfunction, to reverse the effects of an SSRI. Alpha and beta blockers, you wouldn't necessarily think. I use those for like PTSD. Medications like atenolol and prazosin and terazosin I like for nightmares. A lot of these medications can cause exercise intolerance and fatigue, which is going to make the patient not move around as much, which could lead to weight gain. So those are all medications that I use in psychiatry. And then we've got endocrine stuff like diabetes treatments and other things like that. So glucocorticoids, so like your prednisone, your methylprednisolone, your hydrocortisone. Most patients are not on these long term, some more than others. And so be mindful of that. Diabetes medications, most of the new ones actually help, but a lot of the older ones make things worse. Insulin, sulfonylureas, megalit meglitinides, uh, thiazolid. Let's see if I can get this. Thiazolidinediones, TZD. So those are your glitazones and your meglitinides, or your glinide medications, sulfonylureas and an ide. We don't use these a whole lot anymore. Insulin, though, is still, of course, used. And I mean, typically, if you're using insulin, you don't really have much of a choice. And then some of the hormonal things in the birth control type medications, the progestins, may lead to obesity. It's a controversial topic. Medroxyprogesterone, another one potentially. Let's go into the antidepressant antipsychotics for kind of mechanism. So there's lots of ways. A lot of these medications are histamine blockers, which decreases metabolic rate. A lot of them block 5-HT2C, which is one of our serotonin receptors, and that has the effect of decreasing satiety signal, so you don't know that you're full, and increasing carb craving. Um, there's effects on increasing prolactin sometimes, and that can affect weight. A lot of our medications have anticholinergic activity, and that can have effects on glucose and insulin. And then some of these medications increase neuropeptide Y, which also can um, lead to appetite increase. And then a lot of these medications can actually have effect on GLP-1 receptors in the body in the wrong way, right? They don't agonize them, they may antagonize them in some way. So um, the psych meds can make you gain weight in a lot of different ways, and I think people don't really think about all those different ways, and it's complicated. You'd be like, hey, I don't know why this one's causing it because it doesn't block 5-HT2C. Well, maybe it's having effects on prolactin or neuropeptide Y, and like I don't know how much neuropeptide Y is affected by different medications. It's just not something that's out there. So just because you think, hey, this med shouldn't be doing this, it very, the patients always tell me on SSRIs, I'm gaining weight on this. And I used to think, why? And, it doesn't antagonize 5-HT2C. It agonizes it. It's more serotonin. This is not an H1 blocking medication. This doesn't affect anticholinergic activity. Why would this be causing weight gain? Well, maybe it's doing something with neuropeptide Y. Maybe it's doing something with GLP-1s. Maybe it's doing something prolactin. We would measure that, but it could be one of these other things you're not really thinking about. So listen to your patients, trust them when they say that. I think people blow them off a lot of times, saying, "Oh, this person's just eating too much. It's not the med." Um, Another reason could just be that like you're treating their anxiety, and the anxiety was burning calories, and now we don't have that effect anymore. So we're having a good effect, but it's leading to weight gain. Okay, and maybe they need the medication, but now we have to consider the cost benefit analysis of what that medication is doing, and maybe we need to use a different one. Maybe we need to treat the obesity in a different way, because we don't want to end up causing diabetes and high blood pressure and things because they're gaining weight, but like we're happy their anxiety is treated. So that it's a very complicated way that these interact. All right, glucocorticoids. How do those cause weight gain? They increase appetite. They lower metabolism. They drive storage of adiposity, which is fat, into the abdomen. The diabetes medications. How do those cause obesity? Insulin leads to storage of glucose, which can cause weight gain. And it also leads to eating to avoid hypoglycemia, can lead to weight gain. So, you don't want to become hypoglycemic. So you eat something and, it's a candy bar or something that contributes to weight gain. But of course, you need to avoid hypoglycemia, but that's another mechanism by which being on insulin can cause weight gain. The sulfonylureas, I don't see these at all anymore, but just to let you know how they cause weight gain, they force the pancreas to produce more insulin, which, right, insulin causes weight gain. We already talked about that. The thiazolidinediones, the TZDs. So the medication that I see in this category sometimes used is pioglitazone. I've heard good things about it for treating diabetes. in patients that like are not quite under control. It helps healthy fat cells store fat. It leads to water retention. However, the weight gained is usually relatively healthy weight. So, and it's usually not very much. And then I'm going to go ahead and start a little bit more into the medications. Um, so that's the assessment I do. And then I also have to assess, do they even qualify? Do they have a condition that would lead me to give them one? All right. So like, what have we done so far? We've assessed what their weight is, kind of what their weight status, their BMI, etc. We've looked at their social history. We've screened for comorbid conditions. We've screened for secondary causes. We've screened for conditions that would affect what medication we choose, their expectations, their motivation. We've done a lab workup. We've checked what medications they're on to see if that might be a problem, because maybe we need to switch something. And now okay, we got through that gauntlet and we've decided, hey, this is a patient that is motivated to take medication, wants medication. um, do they even have is their weight even high enough to treat? Okay, so let's go down the list of criteria by which, okay, we've gotten to this point and now we're thinking, let's go with medication. Is it a yes or a no? First, are they pregnant? Okay, we want them not pregnant. All right, they're not pregnant. Next, BMI over 30. That's who we give it to. If you're over 30 and we've ruled out all this other stuff, we can go ahead and go forward with it. Over 27 with comorbidities. All right, so every insurance company is different, but the one I've worked with in the military, these are their criteria. So another insurance company might have different criteria. It may be similar. I'm going to go over the ones that I'm familiar with just to let you know how I would go through it. So if you're over 30, it's kind of a definite. If you're over 20, what medication we can use first is phentermine. I mean, in my system. So like there's kind of still a formula to follow, but like we can treat the obesity if they're over 30 or greater, actually, right? 30, a BMI of 30 or greater. And I said, BMI is not my favorite, but this is what the insurance companies use to determine whether they will pay for a medication. If a patient's paying out of pocket, you don't have to necessarily follow this as rigorously. But and also with insurance companies, you still have to, we still have to take into consideration that this stuff is expensive. We give everybody this, we're going to bankrupt the nation. All right, so there might be patients that technically qualify that I don't necessarily think need it, right? And it depends on a lot of other factors, all these factors that we're assessing. All right, so over 30 or greater BMI, we can go ahead and go down the road. If they're at 27 or greater with a comorbidity, and now what are the comorbidities? These are the ones that my insurance company has laid out, and I will go through them and explain to you how I can make somebody fit these or not. If I want to give somebody medication, I can find a way for them to meet one of these criteria. It's not difficult. Now, I may not want to do that, but if I really want to, they've actually made it quite easy for me. All right, so let's go through this. If they have diabetes type 2, A1C is greater than or equal to 6.5, their fasting glucose is greater than or equal to 126, or their oral glucose tolerance test is greater than or equal to 200, they have diabetes. I don't even need to worry about it. I mean, it doesn't, the comorbidity or not, doesn't really matter. They have diabetes. I can use the medications under the diabetes criteria. If you have diabetes, you can take GLP-1s. And so, and those are the most effective medications, so we can go straight to it. So that's a comorbidity of BMI 27 or greater that matters less to me. But if I've got a patient with diabetes and they're not overweight, I may not want to go with a GLP-1. I may want to go with a different diabetes medication. But if this is an overweight obese patient, then GLP-1 is a great medication to choose for diabetes. All right, this next one is interesting. So impaired glucose tolerance is also listed on my insurance company. And I have looked up the definition of impaired glucose tolerance, and it is an oral glucose tolerance test between 140 and 199, which technically meets the criteria for prediabetes and not diabetes. And for some strange reason, if you have pre-diabetes with your A1C number or pre-diabetes with your impaired fasting glucose, that does not qualify you to get the insurance coverage. But if your oral glucose tolerance test is in the pre-diabetic range, that's considered impaired glucose tolerance, and they will pay for it for a BMI 27. Is that confusing? So this is, I actually discovered this recently. So I've got an overweight patient, BMI 27. They're pre-diabetic, but their A1C is normal. Their fasting glucose is in the pre-diabetes range. It's not normal. It's in the pre-diabetes range, but their oral glucose tolerance test, which is something we never order, is in the pre-diabetes range. I can give it. So if I find someone with an A1C that's in the pre-diabetes range, and I feel like this is a great candidate for a medication, but their BMI is 29, I could go ahead and order an oral glucose tolerance test, which will probably show them in the pre-diabetes range, because I already know they have pre-diabetes because their A1C was 6.4. We're like one away. Can't do it until they're 6.5, but we're 6.4 pre-diabetes, but their OGTT is in pre-diabetes range. Boom, I can give it to them. You've got someone on the edge, 29 BMI, 0.1 away from having full diabetes. We have to wait for them to get sicker to get the medication. Well, I found a back door here through the OGTT. Kind of ridiculous, but I just found this recently. So yeah, that qualifies them. It'll be paid for. Another one is dyslipidemia. So I found this interesting. It's not like it, and I looked up what is the definition of dyslipidemia. It's an LDL greater than or equal to 100. That's not that high, honestly. How many patients that have a BMI 27 or greater have an LDL greater than or equal to 100? It's most of them. And so it's not just that. If they have an LDL greater than or equal to 100, HDL less than or equal to 40 for men, less than or equal to 50 for women, or triglycerides greater than or equal to 150, or total cholesterol greater than or equal to 200, or they're taking lipid-lowering medication, any of those, their LDL, HDL, triglycerides, total cholesterol, lipid-lowering medication, if any of those criteria are met, they have dyslipidemia. BMI of 27 or greater with dyslipidemia, insurance will pay for the medication. Not a hard criteria to meet. So the OGTT is not a hard, in the pre-diabetes range is not a hard criteria to meet, and dyslipidemia is not a hard criteria to meet. Next one, hypertension. If their systolic is greater than 130 or diastolic is greater than 80, that's hypertension. That's a comorbidity. BMI 27 or greater with a blood pressure in that range, they can get insurance to pay for the medication. Sleep apnea, moderate to severe. If their AHI, their apnea hypopnea index, is greater than or equal to 15, that is moderate to severe sleep apnea. BMI 27 or greater, they qualify for medication. Osteoarthritis. I mean, that's just a clinical diagnosis. You maybe take an x-ray, you feel their joints. If they have osteoarthritis, I mean, that's kind of in many ways, that's a subjective exam finding or diagnosis, right? Like there's not like a lab that tells you. It's not like AHI 15, hypertension 130 over 80. It's just they have osteoarthritis. That's kind of your opinion. That also qualifies them with a BMI 27 or greater. Metabolic syndrome, that's kind of pointless because we've already, so if you have any one of the metabolic syndrome, you have to have 3 to have metabolic syndrome, but you only have to have like dyslipidemia by itself to get qualified. So like listing metabolic syndrome is kind of pointless because you've already met the criteria before you meet the criteria for metabolic syndrome, right? You already have, just having one of the symptoms of metabolic syndrome, other than increased weight, waist size, other than that one, if you have any of the other criteria, that by itself will get you there. So I don't even know why they list that. It's kind of redundant. If you have metabolic associated steatohepatitis, so not MASLD, but MASH. So you have to have like full on hepatitis, not just the precursor of that. Okay, so that's a pretty severe condition. Most people don't have that far, but if you do, that, with the BMI 27 or greater, and remember, if you have 30 or greater, we don't need to worry about any of this stuff as far as like, can we give them the medication or not? It's only for folks in the 27, 28, and 29 range that we have to find one of these other things to give them the medication. Another one, cardiovascular disease with history of stroke, MI, or PAD, that's peripheral artery disease. So pretty easy. I mean, an LDL of 100, an OGTT of 140. It's not hard. I mean, for a patient with 27, 28, 29 BMI to find one of those criteria. Now, am I necessarily going to give it to them because they meet the criteria? No, I mean, this is just to kind of get insurance to pay for it, right? Like I can give it, I can give them a prescription whether or not insurance will pay for it or not. And I cannot give it to them whether insurance will pay for it or not, right? So just because they have this isn't like a you have to do it. It's more like if you feel like it's indicated and you're trying to help them get this medication paid for and you can find one of these issues, then that's, I mean, then they can afford it and they can actually take the medication, which is what you want for them. Okay. So I'm just showing you how easy it is to get these approved. A lot of people say, oh, it's so hard to get it approved. I mean, it depends on the insurance company. You need to look at what their rules are. This is what my insurance company that I deal with, their current rules are. And these criteria are not that hard to meet. All right. If we have a pediatrics patient, you have to be greater than or equal to 12 to take any of these medications. There are some medications you can take less than that. I will talk about that later. You need to be over the 95th percentile. We're looking for percentiles rather than BMI when we're looking at pediatrics. People have to have a trial of lifestyle modifications for 6 months. Pretty much everyone has done that. And then let's look at the treatment goals, and then we will finish up today's episode. So, all right, we're treating their obesity. What is our goals? Well, my goals would be 1 to 2 pounds on average of weight loss per week. So 1 to 2 pounds is, I don't know, about half to 1 kilo per week. We don't really want to lose faster than that. If we're slower, it'd be better if we were at 1 to 2, but I'd be more worried about too fast. If they're losing too fast, I would probably lower the dose. They may be like that they're losing too fast, but it's actually really not good for them. It can cause a lot of sagging of skin in the face and other parts of the body. So we don't really want to lose the weight too quickly. It could also cause malnutrition and some issues there because they're just not eating at all. And so, like, I'm shooting for that 1 to 2 pounds per week weight loss. We want to keep that up on average until we meet our goals. So we want sustained loss. And then ultimately, we're looking for improved health, right? Diabetes. So the patient doesn't have diabetes yet. If you have a 5% weight loss, there is a 50% reduced risk of developing diabetes. With a 10% loss, there is an 80% reduced risk. And with a 15% loss, there's a 95% reduced risk. Let's just take that like right now. If you're 200 pounds, a 15% weight loss is 30 pounds. So going from 200 to 170, you have decreased your risk of diabetes by 95%. 30 pounds is honestly not that much. Okay, say you have a 400-pound patient. That's 60 pounds. I mean, there's still 340 pounds. It's a decent amount of weight loss, but they're still very heavy. But look how much we have reduced. I mean, it may depend on the weight. Maybe someone who's 400 pounds that loses 15% is, this 95% is average. But I mean, 15% of weight, pounds of 15% weight loss is a very achievable goal to get a very huge outcome of 95% reduced risk. And like, if you can't get to 15%, 10% is still great at an 80% reduced risk. So and even 5%, a 50% reduced risk, 5%, that's what, 10 pounds on a 200-pound patient. You lose 5% and you sustain that, you have a 50% reduced risk of diabetes. That's a big reduction for not that much weight. And the patient may not be happy with that weight loss, but like, that's a pretty massive benefit, even with a very mild weight loss. And this is cool. Even a temporary loss conveys reduction of risk. So even if you lose 10% for a year or two, and then maybe you gain it back, you've still had some risk reduction just because you had that weight off for a certain period of time. It's not going to be the full 80%, but you have still decreased your risk. So diabetes is very much affected by weight. Um, let's look at some other health conditions. So A1C, blood pressure, and lipids. So we're looking at three different factors here. Um, you're going to see an improvement in their A1C. So their A1C is going to go down, their blood pressure is going to go down, and their lipids are going to go down with just a 3 to 5% weight loss. So we lose 3 to 5%, we're already seeing improvements in these numbers. So a very small weight loss, we're getting improvements in these metabolic factors. Sleep apnea, okay? 10% weight loss improves AHI and symptoms. AHI meaning, right, that's how the apnea hypopnea index, remember I said it had to be 15 or greater to like count as a comorbidity for the insurance coverage. We get 10% weight loss, and we're going to have meaningful impact on that. What is apnea hypopnea index? So apnea means you stop breathing. Hypopnea means that your oxygen saturation drops. So you're still breathing, but you're not taking in enough oxygen. And that number is how many times does it happen per hour. So if it was 15, that would mean that you would have 15 combined incidences of either apnea or hypopnea per hour. So if you sleep 6 hours, it's happening 15 times 6 times, right? So what is that, like 90 or something like that? So that's a lot of times that you're in they all those instances may be hypopnea. They may not even be apnea, but it's bad, right? And so with 10% weight loss, you're starting to potentially see resolution of sleep apnea symptoms. You could even get to the point where you don't require your CPAP anymore if you lose enough weight. And with just like I said, and maybe this you still need the CPAP, but it's not enough. But with that 10% weight loss and the CPAP, we're controlling the sleep apnea really, really well. All right. And then last one I'll look at is fatty liver. So 5% weight loss reduces steatosis, so that's fat in the liver. 7% loss of weight resolves inflammation, which is caused by fat in the liver. And a 10% weight loss improves fibrosis, which is incredible because fibrosis is what happens when you have cirrhosis, which is your liver's not working anymore, right? And you can get cirrhosis from fatty liver. So that's not just drinking or other poisons. From just fatty liver, you can get cirrhosis. And with this 10% weight loss, you are improving your risk of that happening. So with, we're looking at between 5, 10, 15% weight loss. We're getting massive benefits for diabetes, for blood pressure, for cholesterol, which is linked to all that's linked to heart. Those are all linked to heart disease, right? So you lower your A1C, your BP, your lipids, you're decreasing your risk of heart attacks, strokes, peripheral artery disease, etc. We're decreasing our risk of sleep apnea. We're reducing our risk of cirrhosis, right? And so I think that's something you want to hammer home with the patient. It's like, okay, you may have only lost 30 pounds, but you've drastically decreased your risk of all these diseases. And you're probably going to live a lot longer without having them because of that. And so let's pat ourselves on the back for that achievement, right? You may, maybe you wanted to look differently, but wow, look how much healthier you are. Look at these numbers. This is incredible. Maybe you don't even need to take medication now to treat this other disorder because your weight is improved. All right. So that's how I assess patients. So we went over assessment. We went over what the factors are that would lead me to want to start someone on a medication or be able to get it covered by insurance. And then we looked at kind of what our goals are from a health standpoint. The next slide, I have a list of all the medications that we're going to go over. I'm not going to read through this list. I'm just going to start our next obesity episode. I'll have an ADHD episode first, but we'll do our next obesity episode, and we'll start with the most important medication, phentermine, because that's the one you pretty much have to start with no matter what else you end up on, unless you're paying out of pocket. But most people are going to start with phentermine, so we'll start with phentermine, and we'll kind of go down the list of importance and kind of categories and so forth. So we're finally actually getting to the medications, which I think everyone will find exciting. It's exciting for me. Medications is what I like. That's why this is your brain on drugs. And I hope you got a lot of information out of this, and maybe you're feeling like, yeah, I think I could do this. And the thing is, if you keep listening, you totally can. I will tell you every risk that these medications pose, how to look out for it, what to do about it. There's no reason why any physician should not be able to prescribe these medications, because, I mean, when we think about it, every disorder under the sun can be linked to obesity. We talked about that several episodes ago, including most mental health disorders. And so this is something that all physicians should feel comfortable treating. And your patients are asking you for it, and maybe you don't know what to do. And that's what this podcast is about, is I'm bringing you step by step through it to give you the comfort so that you don't have to fear that you're going to harm the patient, because I think that's what doctors fear. They fear they don't know what they're doing, they're going to harm the patient. We are going to address all your concerns. So thank you so much for joining me, and I hope you will join me next time. I will see you then.